Welcome everyone to Knowledge Club, but it is a special event today. It is a summer student speaker series. And we're inviting you because we have two amazing summer students who wanted to get some extra presentation practice into their summer work with CHI. And they have a very relevant presentation. And I had the honor of seeing a bit of a preview beforehand, and it was so amazing and so fun and so interactive that I was like, we must tell everybody about this presentation and share it with the world. So I'll give you guys a bit of a brief overview. We've got Megan Harmon here. She is a fourth-year undergraduate student studying sociology at the University of Calgary. And she's doing a co-op with us this year. And she's very excited about COVID, writing a literature review about COVID, doing some statistics work. And she's doing that alongside Madelyn Lowe. And Madelyn Lowe, or Maddie Lowe, she is a fourth-year undergraduate student at Brigham Young University in Provo, Utah. I don't think she's in Utah right now, but she's been in Utah most of the summer. And she's studying statistics with an emphasis in statistical science and a minor in mathematics. So I'm super excited today. I also wanted to say, as moderator, this is an extremely interactive presentation and it's really, really fun. Can we all please turn on our cameras? If you're not, if you're able to turn on your cameras, we won't get in trouble if you don't, but it's really fun and we want to see your faces because there's truly a lot of interaction with it. So yeah, I'm super excited. Anyways, Maddie, Megan, take it away.
Awesome. Thank you everyone for joining today, and thanks for the introduction, Chelsea. Before we begin, we'd like to also thank the Center for Health Informatics for our summer student opportunity, and specifically give a shout out to Chelsea Dr. Chick and Danielle Southern for including us in their work and supporting us through our learning so far. Today, we will be demystifying common COVID-19 misconceptions, which is also the topic of a literature review that Megan and I have been working on with Chelsea and Danielle.
All right, so our presentation will begin by first exposing some of the myths regarding the global pandemic that have circulated through the media and conversation. We will briefly discuss our methods used for conducting our literature review, and then the remainder of our presentation will be formatted as an interactive multiple choice quiz, so have your cell phones ready, that reflects some of the common COVID-19 misconceptions from our literature review. The answers will be revealed and supported by systematic reviews or studies that we found while searching databases. We've also included some fun little visualizations of COVID-19 data in Alberta. After the interactive quiz, a call to action and how to approach misinformation will be presented.
Okay, so throughout our summer so far, we've again had the opportunity to be involved in writing a literature review. And this review addresses the common misconceptions about COVID-19. And we want you to think to yourself right now if you know someone or if you are someone who believes a COVID-19 myth. What is the myth? Where did this come from? Has the person you know or have you taken the proper steps to prove or disprove the idea? We noticed that through the media and through conversations, a lot of incorrect information about the pandemic has gone around. You may have heard some of the myths that are on the slide. And some of these myths are things that we wish were true, and that's why we accept them and they gain traction. But it's also important to recognize that the absolute claims that are being made, and they're usually not supported with a ton of credible information. So the myths that you can see on the screen are very specific, but for the purpose of our literature review, we're more concerned about the broader areas of misunderstanding in order to get a more general scan of what people are not understanding. So in an attempt to provide clarity among confusion, we explored 5 broader categories that sort these granular myths.
All right, so beginning on May 5th, 2021, we searched through the databases of Medline Ovid, Web of Science, and Google Scholar using key terms such as misconceptions, myth, debunk, demystify, COVID-19, and coronavirus. These terms were combined using Boolean operators and an OR. We were able to generate a wide range of papers exposing common myths surrounding COVID-19, which we then sorted into the 5 broader categories. So we have chosen an icon to represent each of the 5 categories that will appear throughout the rest of the presentation. The categories include public health measures and interventions, public safety, screening and testing, risk factors of transmission, risk factors of severe outcomes, and vaccination and immunity.
After we populated the 5 different categories with our list of myths from our first database search, we did another search in Medline, Ovid, Web of Science, and Google Scholar to find more systematic reviews and studies on the broader topics. The key terms were specific to which category we were focusing on. So for example, the key terms for the first category of public health measures and interventions included words like masks, distancing, lockdowns, and border closure. And some of our references were also taken straight from the reference list of similar literature reviews. The papers that we included had information that corrected the broader areas of misconceptions, and this process was repeated for each of the 5 different categories that you saw from the icons on the slide before. Okay, we are now going to start the bulk of our presentation, which will act like an interactive quiz. The topics we will discuss will be introduced by a slide that shows a multiple choice question. And if you'd like, you can pull out your phones or on your laptop and follow this link. The room code is CHI 2021. We'll give you a few minutes now. The quiz is anonymous. No one will be able to see your answers. I won't be able to see the answers. It's simply just to get you thinking and test your knowledge about COVID-19. We hope it's fun, but also informative. And each question will pop up one at a time. And then the next question will load when the multiple choice slide shows on our presentation. Each source that we get the information from will be listed on the bottom of our slides. And the questions will walk through some of the misconceptions in our paper and are separated by each of those 5 categories. So I'll input this link in the chat as well. If people are wanting to join online, that means you'll just have to scroll between screens. Otherwise, we can keep our phones out, and I don't know if I can see who's joined, so maybe we'll just give it a minute to wait. Okay, we'll just continue now.
All right, so which face covering is associated with the highest level of protection from COVID-19 infection? A, medical procedure masks, B, cloth face masks, C, N95 respirators, or D, face shields?
Okay, 13 of 15 have answered. It's okay if you don't answer. Oh, 16 people on now.
I missed the room number.
Oh,
Can you put it in the chat or?
yes, the room number is CHI 2021.
Oh,
there we go. We'll just wait a few more seconds then. Okay. There we go. 17 of 17 answered, so I think we can.
Awesome. So N95 respirators. Of the most common face coverings that we've seen throughout the course of the pandemic, N95 respirators are the most effective as they block roughly 99% of aerosols from being released into the environment. This is followed by medical procedure masks, which block 59%, cloth face masks, which block 51%, and finally face shields, which block only 2% of aerosols. When compared with no device, face shields do not significantly reduce the aerosols admitted into the environment, whereas the N95 respirators, medical procedure masks, and cloth masks did significantly reduce aerosol emission. What we can take away from this is that different types of face coverings can greatly assist in limiting the spread of COVID-19. However, face shields are not effective devices for blocking small respiratory aerosols.
Okay,
Right.
the next question should be popping up.
When individuals do not wear a mask, their risk of infection or transmission is roughly how many times greater than someone who is wearing a mask? 5.6, 2.5, 1.4, or 8.1?
Fourteen of 17. I'm just waiting on one. Okay, we're all in.
5.6. So according to a systematic review, those who wore a face mask had a 3.1% chance of viral infection or transmission, whereas individuals who did not wear a mask had a 17.4% chance of viral infection or transmission. Therefore, we can understand that when individuals do not wear a mask, their risk of infection or transmission is roughly 5.6 times greater than someone who does wear a mask. When individuals are socially distanced less than 1 meter apart, their risk of infection or transmission is roughly how many times greater than someone who is socially distanced more than 1 meter? 2.7, 1.5, 0.9, or 4.9?
Of us, 12 of 17. 14, 15, 17. Okay.
4.9. According to the same systematic review discussed in the previous question, individuals at a distance greater than 1 meter had a chance of viral infection or transmission of 2.6%, whereas individuals at a distance less than 1 meter had a chance of viral infection or transmission of 12.8%. Therefore, individuals who do not socially distance at least 1 meter apart from others have a chance of viral infection or transmission that is roughly 4.9 times greater than someone socially distanced more than 1 meter.
Awesome. Okay. These next few questions might be kind of obvious, but they're fun still. So, true or false, COVID-19 transmission varies by season? Um, 12, 14, 15, 16. Okay. We'll just keep going. So, true. This is actually an interesting question that I was surprised they kind of have an answer for already, because COVID has only really been around and seen seasonal variation and seasonal change for just 1 year, just over 1 year. But despite the limited amount of time the coronavirus has been around, we've noticed trends in this virus that are similar to other respiratory viruses. In a study by Gavenciak et al., the thing is at the bottom, the source, a shift from winter to summer or from colder to winter seasons shows a decrease in the transmission of COVID-19. Or in other words, colder months tend to have higher COVID-19 case rates, while warmer months tend to have lower COVID-19 case rates. The study also claims that seasonal variation may have a greater effect on transmission of COVID-19 than do individual non-pharmaceutical interventions, or NPIs. And NPIs are just actions other than like vaccines and medicine that are taken to slow the spread of an illness. So that doesn't hold true for all the effects of all interventions combined. So seasonal variation may have a greater effect on the transmission of COVID than washing hands does by itself, or disinfecting surfaces does by itself. But washing hands combined with distancing, disinfecting surfaces, border closures, all of those taken together typically surpass seasonal variation, the impact of transmission from seasonal variation. Okay, next question, true or false? COVID-19 transmission varies by geographic location. 15, 16, 17. Awesome. Okay, true, actually. This one, Megan and I found to be super interesting. On the paper we read was super interesting. Some speculate whether where you live in the world actually affects COVID-19 transmission. And the paper we read used the ordinary least squares regression method, or the OLS method. And they claimed that an increase in 1 degree in latitude from the equator, so 1 degree up or down, is related to an increase of 4.3% of COVID-19 cases. So in general terms, the further you're located from the equator in latitude, the more COVID-19 cases you're expected to see. And additionally, being 1,000 kilometers closer to the equator apparently implies that 33% less cases implies there are 33 less cases per million people. We thought that was very interesting in the paper. So going along with this trend in weather and location, Megan and I were encouraged by Danielle to try to visualize trends between COVID-19 case rates and average temperatures. And so we compiled on an Excel data from Alberta Health Services for active case rate in the Calgary local geographic areas, those LGAs listed. And we gathered the temperature data from the Government of Canada from that link there. And we averaged the active case rate and temperatures for each week in the month beginning in April 2020. And we just put the remaining days in the month into the 4th week's average because it's not perfectly 4 weeks. On our plot, we see vertical lines of certain government interventions that we grabbed from the COVID tracker, the CHI COVID tracker, to try to further explain the trends along with just the temperature. And on the bottom, you see the month, the x-axis, you see the month from April 2020 to June 2021. And then the y-axis on the left is the average active case rate, which is represented by the orange line. And then the y-axis on the right is the average temperature, which is represented by the blue line.
So looking at this plot, we can see that from April 2020 to January 2021, warmer months have lower average active case rates and colder months have higher average active case rates. But from January on, this trend seems to dissolve. This is when we became curious as to whether this had something to do with the government interventions. So what we can see is that active case rate is not only subject to temperature fluctuations, but we should also look at a comprehensive number of factors to fully understand the trends in COVID-19 cases.
Okay, next question should be popping up. So compared to other coronaviruses, SARS-CoV-2, the virus specific to COVID-19, tends to have a shorter survival time, a longer survival time, or an equal survival time on surfaces. We'll just wait as those are rolling in. 14 of 17, 15, 16. Okay, we'll just continue then. So compared to other coronaviruses, SARS-CoV-2 tends to have a longer survival time on surfaces. So among the infection of COVID-19 through human-to-human contact and also aerosol respiratory droplets, which is why we wear PPE, face coverings, eye coverings, and whatnot. It's been speculated whether transmission is also possible through inert or inanimate surfaces. Protocols have been put into place that support frequent disinfection of surfaces and washing of hands or using hand sanitizer. And these practices would really only be beneficial if the virus could be sustained on a surface long enough for someone to come into contact and be infected. A systematic review by Marzoli states that on glass, steel, polymer banknotes, and paper banknotes, SARS-CoV-2 survived up to 28 days when measured at room temperature and under laboratory conditions, which is double the survival time for other coronaviruses, which survived up to 14 days. Another study by Chin et al. Adds that on surgical masks, SARS-CoV-2 was detected up to 7 days following contamination. Compared to other coronaviruses, just in general terms, SARS-CoV-2 tends to survive longest. The disinfection of surfaces and our hands is thus an appropriate precaution that we should take to slow the spread. Additionally, we read that exposure to sunlight, artificial sunlight, compared to environments with an absence of light is actually related to a lower survival time of coronaviruses. So in a 1 hour period, SARS-CoV-2, it survived for the entire in a 1 hour period, SARS-CoV-2 survived the entire hour period for a dark environment, but less than 1 hour when it was exposed to artificial sunlight environment.
All right, so what are the most common symptoms among COVID-19 patients admitted to the ICU? Cough, fever, and fatigue, cough, fever, and shortness of breath, headache, fever, and loss of taste or smell, or headache, fever, and nausea.
Okay, we're just waiting on people. 7, 8, 9, 10. Nice.
Cough, fever, and shortness of breath.
Click.
So according to a systematic review of predictive symptoms and comorbidities for severe COVID-19 and intensive care admission, 67.2% of those admitted to the ICU had cough, 62.9% had fever, and 61.2% had shortness of breath. They also found that among the most prevalent symptoms among severe COVID-19 patients were cough, fever, and fatigue. However, shortness of breath was the only symptom that was significantly associated with both disease severity and ICU admission, where patients with shortness of breath were 6.6 times more likely to be admitted to the ICU. This means that it's incredibly important to identify when COVID-19 patients are experiencing shortness of breath, as it has a strong likelihood to lead to severe disease and ICU admission. True or false? Only adults over the age of 65 are at risk of death from COVID-19 infection.
Awesome. 10 of us. I'm going to re-paste in case people got kicked out last time. They want to join? Okay, 12 of 17. Okay, we can probably continue.
False. So although the answer is false, the age-specific infection fatality rate is very low for children and young adults. Children 10 years old have an IFR of 0.002%, and adults age 25 have an IFR of 0.01%. But these rates increase progressively at age 55, where the IFR is 0.4%, age 65, where the IFR is 1.4%, age 75, where the IFR is 4.6%, and at age 85, where the IFR jumps to 15%. What we can see here is that COVID-19 is especially concerning for older aged adults, but the risk of developing a severe case is not strictly limited to this demographic.
Perfect.
So Maddie and I have visualized the percentage of ICU admissions and deaths in Alberta for COVID-19 patients, comparing those with no comorbidity, 1 condition, 2 conditions, and 3 or more conditions. We can see that an increase in an individual's number of comorbidities relates to an increase in their likelihood of death. So in other words, individuals with multiple comorbidities are at a higher risk of death compared to those with fewer or no comorbidities. So as we can see here, during the first wave in Alberta, 3.32% of COVID-19 deaths were individuals with no comorbidities.
This is going to be confusing. It's a click, click, click arrow thing. Thanks for taking over, Chelsea.
And then 6.11% were individuals with 1 condition. 16.57% were individuals with 2 conditions, and 74% were individuals with 3 or more conditions. A similar trend holds for the second wave, where 4.9% of COVID-19 deaths were individuals with no comorbidities, 6.97% were individuals with one condition, 13.89% were individuals with two conditions, and 76.36% were individuals with three or more conditions. And finally, during the third wave, 2.51% of COVID-19 deaths were individuals with no comorbidities. 6.72% had one condition, 13.47% had two conditions, and then 77.31% were individuals with three or more conditions. Considering this information, individuals with multiple comorbidities have a severe risk of death after contracting COVID-19 compared to those with no comorbidities. However, there still remains a risk of death for individuals with no comorbidities, as well as roughly 20.64%. The next slide, 20.64% of COVID-19 patients admitted to the ICU in Alberta have no comorbidities. Therefore, regardless of an individual's medical history, precautionary measures should be taken to reduce the spread of COVID-19 and minimize the experience of severe outcomes.
Okay, the next quiz question. Which of the following is the most sensitive method of COVID-19 diagnosis? Or in other words, which is the best at correctly identifying infected individuals? A, reverse transcription polymerase chain reaction, or the RT-PCR tests. B, computed tomography, or CT. C, fever measurements, or D, point of care POC methods. We'll just wait. We're at 12 of 17, 13 of 17. This is probably what we'll get. So we can move on. So A, reverse transcription, RT-PCR tests. With the rapid spread of COVID-19 and despite efforts to follow all mandates and guidelines, many of us have experienced symptoms or know people who have experienced symptoms associated with the virus. As symptoms of COVID become increasingly present, the demand for rapid diagnostic testing also increases. Individuals want to know whether their symptoms are due to COVID-19 infection or if they're due to another infection or contaminant. A common concern is whether the diagnostic tests that are being used are actually accurate and reliable ways of gathering results for their case of COVID-19. A systematic review by Boger et al. States that the PCR technique is in fact the most sensitive method of diagnosing COVID, where sensitivity is the ability to correctly identify infected individuals. The RT-PCR test is also commonly accepted as the gold standard for rapid screening, and it detects the RNA of virus in samples such as nasopharyngeal swabs or bronchial aspirate. The computed tomography or CT technique is actually the second most sensitive method according to the systematic review. And it works to make up for some of the limitations of PCR testing. So that could be making up for false negatives and whatnot. And although subject to false negatives, false positives, and inconclusive results, RT-PCR testing shouldn't be rejected as a dependable method of detecting COVID-19.
How long have RNA vaccines been researched? 1 year, 2 years, 7 years, or over 10 years?
Ooh, okay, we're at 10 of 11 of 17. 12. Perfect. 13. Yeah, we could probably move on.
So over 10 years. The research that assisted the development of the COVID-19 vaccine did not begin with the onset of the pandemic. For decades, researchers have been paying close attention to similar coronaviruses that can cause severe acute respiratory syndrome and Middle East respiratory syndrome. RNA vaccines in particular have benefited from over 10 years of strong research, some of which was aimed at developing cancer vaccines. But it is because of this foundation of scientific research that allowed for strong COVID-19 vaccine candidates to be put forth relatively quickly. However, concerns regarding an incomplete or rushed development process have appeared, despite all efficacy and safety evaluations being appropriately conducted and completed. According to Immunize BC, vaccines take an average of 10 years to be approved. And after each phase of the development process, funding is needed, which often causes these long delays. This insufficient funding usually means that all trial phases will be conducted one after the other. However, the public health emergency caused by the COVID-19 pandemic ensured that plenty of volunteers and billions of dollars in funding was available in order for companies to take the financial risk of running tests simultaneously. This allowed for the timely development and approval of the COVID-19 vaccines without compromising safety.
Awesome. We can move on. This will be the last question. So, how many lives does the World Health Organization estimate are saved by vaccines yearly? A, 500,000 lives, B, 700,000 lives, C, 1 million lives, or D, over 2 million lives? Okay, 14 of 17, this is good. We can probably move on. So over 2 million lives. So on the World Health Organization website, they estimate that between 2 and 3 million lives are saved by vaccines every year. In order to kind of comprehend this number, the population of Calgary is 1.336 million, around that. So just over 2 times the entire population of Calgary is the upper estimate of how many lives are saved by vaccines every year. Some individuals can't get vaccinated because of their age or underlying health conditions or allergies. And so this population depends on those who are able to be vaccinated in order to get protection against vaccine preventable diseases. We read that by vaccinating 66% of the population, herd immunity may be achieved for vaccines that are 90% or more, have 90% efficacy or more against all infection. To contrast that, vaccines with less efficacy may need higher vaccination coverage in order to achieve this herd immunity. And herd immunity may not be achieved with vaccines with less than 70% efficacy. Next. Okay, we can move to the next slide. Okay, so Megan and I were also asked to find a way to visualize the active case rate by percent of population of Alberta that has at least 1 dose of the COVID vaccine. So we created a scatter plot where the x-axis is the percent of population with at least 1 dose of the vaccine, and the y-axis is the active case rate per 100,000 people. Each point, we can probably click to the next slide to visualize this. Perfect. So each point on the plot represents an LGA, or the local geographic area, for a zone, where each color represents a zone represented by the legend on the side. Yep. The horizontal line represents the average active case rate per 100,000 people, which decreases from, on May 31st, our start date, 152.6 to 15.6 active cases per 100,000 people on July 12th. The vertical line represents the average percent of population with at least 1 dose, which increases from 48.2 to 55.4% from May 31st to July 12th. So now yeah, so now we can click play on this and then we'll notice the trend and then we'll watch it again. Awesome. So the overall trend we see is that as more people are vaccinated, the active case rate goes down, which to me is super satisfying to see all the points shift down and to the right. And we chose to just keep the axes the same so we could see how they move on the same plot. Obviously, this trend that we see is due to more than just vaccination numbers, but vaccines definitely play an important role as explained from the past few slides. Nice.
Oops. Oh no, I did it right. Okay.
Yeah. So now we've completed the question bit of our presentation. We're almost done. You should be able to see your scores, but our findings in conclusion for that, our findings support the use of face masks, social distancing in all public spaces, screening and testing for COVID-19 using the RT-PCR technique is definitely a sensitive and reliable method that should be used. And although COVID-19 is especially severe for older aged adults and those with multiple comorbidities, the risk of developing a severe case is not only limited to this demographic. To slow the spread, disinfecting surfaces and encouraging hand washing are appropriate measures to take. And the data also supports the role of vaccinations among all individuals who can be vaccinated in order to control the COVID-19 pandemic. So now we will move into the misinformation, how to address misinformation part of our presentation.
So the rapid onset of the COVID-19 pandemic has coincided with a global dissemination of misinformation. We ask that each and every one of you here today take it upon yourself to be part of the solution and challenge misinformation. Empathetic, transparent, and honest communication can assist greatly with the process of effectively challenging misinformation. By reinforcing positive norms and habits, such as accessing information from credible and reliable sources, questioning where information comes from, and encouraging others to do the same, we're one step closer to flattening the curve of the infodemic. Healthcare and public health professionals are some of the most trusted advisors when it comes to COVID-19 information. When an individual expresses hesitancy or ambivalence towards public health recommendations, healthcare professionals should acknowledge and empathize with the person's concerns. It is important to remember that any conversation surrounding misinformation should be just as much about building trust and rapport as it is about challenging misinformation. So since information can spread so quickly, it's best to explain misleading and manipulative argumentation strategies in order to ensure that people are resilient. The general techniques of science denial are best understood through the acronym FLIC. So fake experts are usually individuals or institutions that give the impression of being experts without actually possessing any real or relevant expertise. Logical fallacies utilize a strategy that either illegitimate your argument or using irrelevant points in order to undermine the logic of the opposing argument. For example, using a slippery slope argument. So saying something like, if the government forces us to stay home, then eventually they'll take away all our freedoms. So we should just keep going out in public and gathering in groups. So you're basically saying that if A happens, then through a series of steps, Z will happen. So you're equating A to Z. And then with impossible expectations, the strategy demands unrealistic standards of certainty. So saying something that demanding the vaccine to be 100% effective or having no side effects at all in order to be considered safe and effective. And then with cherry picking, individuals will skillfully select data that appears to confirm their position while ignoring all other data. And with conspiracy theories, which I'm sure we're all pretty familiar with, they propose that an event or situation is the result of a secret plot, and that an example would be arguing that the virus was made in a lab in China in order to destroy other countries' economies. So by understanding these 5 techniques, individuals will be better equipped to decipher accurate information from misinformation. So the next time you encounter a piece of information or discourse that you may be unsure about, ask yourself, does this argument follow one of the 5 techniques of FLIC? So once you have identified that a piece of information is in fact misinformation, the next step is to correct the misinformation or debunk. An effective debunking follows this structure. So fact, begin by providing a factual alternative to the misinformation. Next, warn about the myth. Repeat the misinformation, but only once, directly prior to the correction. Then explain the fallacy. Instead of simply stating that the misinformation is incorrect, provide an explanation as to why. It is crucial that individuals see the inconsistency between the misinformation and the correct information in order to shift their understanding. And then finish by reinforcing the fact multiple times if possible. Repetition will ensure that the correct information stays with them. Yeah, and then with that being said, we'd like to thank you again for the opportunity to speak with you guys. We're very passionate about the work that we've done so far and extremely grateful to our wonderful supervisors who continue to provide and support us with opportunities to learn and grow.
For more information on who we are and what we offer, visit our website at coming.ucalgary.ca/CHI. If you are interested in our services, collaborating with our team, or have any other inquiries, contact us via email at chi@ucalgary.ca.